Hi, I'm Dr. Michelle Kittleson, Associate Editor for JACC. I'm delighted to be here with Dr. John Spertus, Senior Author of Effect of Aficamten on Health Status Outcomes in Obstructive Hypertrophic Cardiomyopathy, Results from SEQUOIA-HCM. Dr. Spertus is a cardiologist and the Lauer, Missouri Endowed Chair and Professor of Medicine at the University of Missouri, Kansas City, where he serves as Clinical Director of Outcomes Research at the St. Luke's Mid-America Heart Institute. This exciting topic is presented at ESC, and we are thrilled to have a simultaneous publication in JACC. As a quick summary, Dr. Spertus and colleagues examined the effect of aficamten, a cardiac myosin inhibitor, on patient-reported health status in patients with symptomatic obstructive HCM enrolled in the SEQUOIA trial. I'm going to start with a question about the measures used to assess patient-reported health status. So the FDA has qualified the Kansas City Cardiomyopathy Questionnaire, KCCQ, as a clinical outcome assessment in patients with HCM. In the primary analysis of the SEQUOIA-HCM trial, the results of the KCCQ clinical summary score were reported. Patients receiving aficamten had greater improvement in this score compared to patients on placebo. Now, in the current study, you examine instead the effects of aficamten on the KCCQ overall summary score, as well as the Seattle Angina Questionnaire. Can you explain why the KCCQ OSS was used and what the findings mean for clinicians caring for patients with HCM?
Absolutely. First of all, I can't thank you enough for your interest in our work, in your willingness to move mountains to actually review and evaluate it fast enough for this simultaneous publication. And it's having been on the past editorial board of JACC as associate editor and watching the energy, the enthusiasm, the author-centeredness that the new team has approached, it's remarkable. And so I just wanted to thank you and give a big plug for JACC because our experience in publishing there has really been second to none. And so really, thank you very much for the opportunity. I've spent my whole career trying to figure out, what's important to patients and how do our treatments actually affect those outcomes that they care about. And clearly, patients care an awful lot about their symptoms, function, and quality of life. And, as clinician scientists, we often are enamored with the anatomy, the physiology, the pathophysiologic mechanisms by which disease progresses or a treatment interferes with the progression of that disease. But those are really surrogate outcomes. I mean, they do help us advance the field and advance knowledge and generate new therapies and new hypotheses. But no patient feels the magnitude of their LVOT obstruction, what their EF is. What they are really aware of are their symptoms, how those symptoms impact their ability to do physical activities, to engage in social activities, and their quality of life, their perception about given these symptoms and function compared with how I'd like to be, am I satisfied with that or not? Both the KCCQ and the Seattle Angina Questionnaire basically try to individually capture patients' symptoms, function, and quality of life. And the KCCQ, as an example, was really developed for patients with heart failure. It's been shown to have very strong psychometric performance in patients with HFrEF, HFpEF, valvular heart disease, and HCM, because again, as I said earlier, patients don't feel their EF. They don't feel their LVOT gradient or their aortic stenosis or MR volumes. What they feel are the symptoms of fatigue, shortness of breath, and how it impacts their physical and social functioning and their quality of life. And in the clinical summary score of the KCCQ, it is basically replicating the New York Heart from the patient's perspective by combining the physical and the symptom scales. But patients also care about their quality of life and their social functioning. And the overall summary score captures, it integrates both the symptoms, the physical and social limitations, and patients' perception of their quality of life into a single scale from 0 to 100. And it turns out that the device side of the FDA has qualified all of the scales of the KCCQ, But the drug side has only qualified the physical function scale, the symptom scale, and the clinical summary score. So a lot of clinical trials are elevating the clinical summary scale, essentially the New York Heart, and ignoring the social impact or the quality of life impact of a disease as a primary or secondary endpoint, because that is the foundation by which a drug might be approved by the FDA because of it having qualified just those scales. But we wrote this for clinicians and clinicians and patients care about all of it, right? So that's why we like to emphasize the overall summary scale. And it turns out that HCM differs from most other etiologies of heart failure because it also has a significant component of chest pain, whether this is due to increased endomyocardial stress, whether it's due to microvascular dysfunction. As an outcomes researcher, I don't care, but I know patients have a lot of chest pain. And so we wanted to capture chest pain as well. And so this is the first trial that seeks to supplement the KCCQ with a chest pain measure. And even though the Seattle Angina Questionnaire was developed for traditional angina, and there are some things that won't be relevant, it does capture the impact of chest pain and the frequency of chest pain quite well. And it's written in a way that patients with HCM are able to understand how to complete it, and it's relevant for them. And so what this study does, by focusing on both the overall summary score to capture the totality of the impact of the disease on patients' lives, supplemented with the Seattle Angina Questionnaire to capture with greater granularity the impact of chest pain, I think provides the most complete assessment of cardiac myosin inhibitors on obstructive HCM to date.
Well, you heard it here first. You can't get a better summary of the historical and clinical context of these scores. That was amazing. And you mentioned something so important. You said patients don't really care what their EF is. I love that. Of course, that really focuses us on what should matter. And what's interesting about your study is that you observed a potential discordance between the severity of exercise capacity limitation and reported health status in patients receiving aficamten. So how should clinicians reconcile this as they counsel patients who are starting a cardiac myosin inhibitor for symptomatic obstructive HCM?
So I apologize, but if you could restate the question, because I'm not quite following what discrepancy you're referring to.
Amazing. So yeah, totally. So when you look at the improvement in the VO2 max, the maximal oxygen consumption on cardiopulmonary exercise testing, there is not a great correlation between those patients who have an improvement in their VO2 max and improvement in their symptoms. Some patients had minimal improvement in their VO2 max, yet their scores from the KCCQ OSS or the Seattle Angina Questionnaire did improve. So how do we as clinicians make sense of that? And you might tell me that's a subject of future studies, stay tuned. And how do we counsel patients on what to expect when they start these medications?
Okay, so that's a great question. So first of all, just for clarity, we actually did not do an analysis of the change in B.02 and change in KCCQ. Rather, we looked at the baseline, how limited they were to start with, and we found no heterogeneity. So the benefit was similar by how limited they were. But it really bespeaks a much more important question, which is, B.02 is a remarkable physiologic technique for understanding the pathophysiology of cardiac functioning with the body. And yet, is that really a clinically relevant outcome? And patients very rarely exert themselves to their absolute maximum capacity. And what the KCCQ is capturing is the impact in their routine daily lives, not in the artificial setting of exercising to 85% of their maximal predicted heart rate, or they're getting a certain ventilatory quotient. I mean, it's really measuring something different. And so I think that B.02s are extraordinary for helping us try and understand pathophysiology and think about alternative therapies to improve that, and do give mechanistic insight. But again, I think it's a surrogate for patients. I think it's the KCCQ that gets really the relevant and meaningful outcomes because this is what they're experiencing day to day. And for me, if I had the choice to, have a 0.03 mil per kilo improvement in my V902 versus a 10-point improvement in my KCCQ, I can only choose one. I would definitely choose the latter. And so, again, I'm not trying to create discord with my physiology colleagues at all, but they're really measuring different things. And leaping off of your idea, trying to understand what is it that impacts, what leads to the greatest improvement in the KCCQ, and are there baseline characteristics that portend benefit? And we have tried to sort of look at this in a very preliminary way in some work we did with the Explorer study and mavacamten, and we're hoping to expand it here as well. And the reason that's important is that if there are things like baseline LVOT gradient, baseline KCCQ, gender, age, things that influence the potential benefit of treatment, then being able to personalize that to a patient and telling them why it's worth paying these copays, trying these drugs, I think is very valuable and is an important future clinical way of doing it. And so we want to do that work. I also think that one thing that's remarkable, and this applies to myosin inhibitors, it applies to anti-angiol therapy in the ischemia trial, is that you have the opportunity to start a medical therapy and to collect a baseline KCCQ or for anti-angiols a SAC, and then to intensify that therapy and see how the patient's improved. And if they've gotten better on their health status has gotten better, not only does it reassure you you've started a good therapy, does it create an opportunity for you to recognize that therapy hasn't worked. I need to intensify therapy, maybe thinking about septal ablation or something like that. But it allows the patient to track how they're doing, to understand and be a more active participant in care by following their health status and understanding, oh, I'm taking aficamten to improve my quality of life. They come back a month later and, oh, I'm feeling better. What did my KCCQ show? Oh, it got a lot better. And then in the SEQUOIA trial, what's really impressive is how fast the KCCQ decreased after the drug was stopped. When we have seen treatment effects this big, say from TAVR or from MitraClip, right? You can't unclip the mitral leaflets. You can't pull out the TAVR, so you can't see what happens when you remove the intervention. But with a drug like aficamten, when it stopped, to see the patient's health status decrease so rapidly was really impressive to me. And to me, we worry a lot with antihypertensive therapy or statins. How do we get patients to stick with the therapy? We know a third to a half stop within 6 months. I don't think people who take this drug and get better are going to stop, because they really felt a lot better on it. And when they stop it, they go right back to where they were.
Amazing. Well, I feel as a clinician who cares for patients with hypertrophic cardiomyopathy, absolutely grateful to you for all the work you have done that allows me as the clinician sitting across from the patient in clinic to counsel them and give them guidance of what they can expect when they take this medication. So for all the clinicians out there excitedly listening to this podcast, the reason to read this paper, the reason it will impact your clinical practice, it will give you a better understanding of how to counsel your patients of what to expect when they start this medication, because as Dr. Spertus so beautifully said, they don't really care what happens to their VO2 max. They care what happens to their health status, and this gives us great insight into that. Dr. Spertus, I can't thank you enough for taking the time to do this. We are so delighted to have a chance to broadcast your amazing work to the world.
Thank you so very much. Really appreciate the opportunity.